Bismillah, alhamdulillah, wa salatu wa salam ala rasulillah. So I'm just going to talk in this lecture about follow-up imaging in oncology and how we do it and how we should do it. So to begin with, oncology CTs in particular, oftentimes we might feel they're a little boring, lots of measurements, lots of numbers, a little repetitive. And there is some truth in that, of course, but I think we can do it well. We can do it better than we do. I want to look at the response criteria which we can use to sharpen up our reports. Why bother? Well, we have, in this hospital at least, we have a large oncology caseload, and many hospitals would. Imaging does play a big role in management. It does guide the oncologists, and they do make their decisions pretty much based on what we tell them in our reports. And for this reason, it's important we have good quality reports which help them in that process. Unfortunately, oftentimes we don't, and maybe we're rushing through, we don't do a good job, and we're not actually helping the oncologists, who oftentimes may be more confused by the report than helping them. So I want to talk about the actual response criteria, and these were obviously developed for clinical trials, but the principles and rules behind them can actually help us in our reporting and make it easier. Cancer therapies have evolved a great deal over the last several years, from broad-based chemotherapeutic agents to much more targeted agents which will specifically attack receptors and certain targets, and even immunological therapies as well. And in the same vein, imaging has also evolved from simple structural assessment up to functional and molecular imaging, to the extent that we can now image specific receptors, like, for example, Herceptin receptors, and that can help with planning treatment as well. The response criteria that we use have also gone through an evolution in parallel with that, and there's a whole alphabet soup of different criteria that we can use. And it can be a bit confusing, like what do you choose and when, but I think I'll work through that in this lecture. So I'll go through some specific criteria, and you don't necessarily need to know the details of these, but learn the principles which will help you in your reporting. The first and earliest was by the WHO, and they would measure lesions in two diameters, multiply them, and then add those numbers together. So this is how they would do it. So you've got, for example, two lymph nodes here with short and long axes. You multiply them, add them up, and then you get a total, and then the same thing on follow-up. And then you can see the percentage change. And then based on that, you can work out the response. So it's either completely responded, or it's partially responded, or progressive disease based on those percentages. And if it's in between, it's stable. Some details were not clarified. How many lesions should you measure? And it's also very sensitive to small changes, which leads to inaccuracy. To correct this, they then developed RECIST 1.0, which was done in around 2000, and they started with a database of patients. They set a certain number of lesions, a maximum number of lesions to measure, and they just did the long axis measurement as a barometer. This also had some limitations, so I'll just go straight forward to RECIST 1.1, which was some years later, where they used a much larger database, and they limited to just 5 lesions to be measured, which actually is easy. And I know oftentimes people do oncology scans and they measure lots and lots of lesions, but it doesn't really help. So if you do 5 good clear lesions and no more than 2 lesions per organ, so only 2 liver mets, for example, or only 2 lung mets, and that's all you really need to do. Any deposits in the lung or liver, for example, you measure in the long axis, and they should have a minimum size before you measure it. Lymph nodes should be measured in the short axis, which we know is more accurate, and again they should have a minimum size before you start measuring. And then you simply add these numbers up, sum of longest diameters, although that is the short axis. You also look at non-measurable disease, so things like, a mental thickening or something like that, which you can't measure. So this is how you do it. You've got lesions, say, in the spleen, which is in the long axis, nodes, which are short axis, a small lesion which is below the threshold for measuring. This would be a lesion in the spine, for example, spinal cord. And this would be non-measurable disease. So there's clearly disease, but you can't really put calipers on it. And then here are the criteria for response. Now again, you don't need to get bogged down in the detail, but just if that sum of diameters reduces by more than 30%, that's a partial response. And if it increases by 20%, that's progressive disease. And then the other categories in between that. Non-measurable disease or non-target lesions, that's fairly common sense, really. So that's a very useful tool. Now, again, you don't have to use that, to the letter, but you can follow that principle, and it should make your reporting easier. There are limitations as well. So a lesion may shrink, but it may change in its appearance and its quality rather than just its size. So it may be cystic or necrotic and so on. So RECIST is obviously not perfect, but it's still useful. There are lots of other criteria, and I'll just go through them quickly. They're useful in specific situations. So the COI criteria is useful in the treatment of GIST with imatinib, and that's a specific type of inhibitor. So the change in size is not so relevant, or it is still relevant, but you need to look at the attenuation of the lesion. Okay? So this is, for example, a lesion in the liver, which has got this sort of enhancing component centrally, and it's reduced in size and in attenuation. And now the size has not changed, but there's an increase in attenuation because there's an enhancing nodule. So that indicates progression. So you need to take that into consideration, basically. So again, this is just a bit of detail here, but the point is that you look at the size as well as the actual attenuation. Okay, so you need to take both issues into consideration. M-RECIST is a similar concept to RECIST, but it's adapted for HCC. Okay, and then the key principle with this is that you measure the arterially enhancing component of the HCC. Otherwise, the principles are similar. Okay, and new lesions must fulfill the criteria for HCC, so it should arterially enhance, wash out, etc. And then that's counted as a new lesion. So it's just like RECIST, but using the concept of arterial enhancement and the other criteria of washout. So again, this is an example. You've got an arterial enhancing lesion, which we know is an HCC. You treat it, and it's reduced in size and not enhancing now. That's just peripheral enhancement, which is reactive. But then, obviously, if there's a new arterial enhancement, then that's of concern. Okay, PERSIST is used in PET CT. Again, this is probably more relevant to research, to be honest. But you've got the SUV based on lean body mass, or the SUL as you call it. So that's just like a measure of how active a site of disease is, how intense the uptake is. And you look at the most intense lesion and then compare pre and post treatment. And it may even be a different lesion. So this, for example, is a lesion here you can see in the left lobe of the liver, and then the uptake has greatly reduced. It's just the same as baseline liver. Okay, and again, there's some detail here. So if there's a 30% reduction or increase, then that tells you whether it's response, partial response, or progressive disease. There are some other criteria which we'll just touch on briefly. There's IR RECIST. Again, you don't need to know the detail of this, but it's just the point that certain immunotherapeutic agents, like the one mentioned here, they can actually cause this flare phenomenon. So as the patient is being treated, the tumor lesions, and the tumor lesions apparently increase, and you may even see new lesions, and that's just the response of the body as it's treating the lesion. And then after an interval, after some weeks after that, then it will respond, and then you'll get an overall reduction. So the point is that don't be put off by this flare. It still may respond after that. RCC, again, that also has another criteria. which looks at the attenuation. So it's similar to the COI criteria, and this is for sunitinib. And again, so you look at the size as well as the attenuation, and that helps you. Okay, so that's just a whistle-stop tour, but I think the important thing is that we can image, and report in a much more efficient way if we try and follow these principles, and we can actually, be more useful in our assessments. And it doesn't take long to if need be, to run the calculation. So if you're doing RECIST, for example, and you might be not sure, is it actually progressive or is it stable? So for those few cases, you can actually do the maths. You can look at the baseline and the follow-up, get the numbers together, and then you can tell, yes, it's definitely progressed, and that can help. So anyway, so far from being this boring number crunching thing, I think we need to see these criteria and this approach as empowering you, and helping you to really, make a difference. So I think that's the conclusion there. Thank you.